Hello and good afternoon, and a warm welcome to this session. Today we're going to talk about transformative clinical decision support for patients with comorbidities, dynamic algorithms that change as patients change. Kieran Walsh is my name. I'm Clinical Director at BMJ, and I'm a older person's doctor turned editor and educator. And my competing interest is that I work for the BMJ. So I'm going to share my screen now, and then we can start. So now you should all be able to see my screen, which states comorbidities tool, treating the whole patient, BMJ best practice. So in this talk, we're going to talk about clinical decision support for comorbidities, and the title is Transformative Clinical Decision Support for Comorbidities, Dynamic Algorithms that Change as Patients Change. It's relevant to doctors and other healthcare professionals, including nurse practitioners and physician's assistants who we know are interested in this field. It's of interest to generalists everywhere, but also to those who are interested in digital health. And I'll say some more about that in a second. But if people are interested in finding more about the tool, helping us develop it further, evaluating it, please do get in touch. I'll show my email address at the end. And so specifically, these are the things we're going to talk about. I'm going to give a brief introduction to our clinical decision support tool, BMJ Best Practice, as it is now. I'm going to talk about the challenges and problems of dealing with patients with comorbidities. I'm going to talk about our own tool, the comorbidities tool from BMJ Best Practice. I'm going to run through a clinical scenario to show how it's used and do a brief demo at the end, and hopefully we'll have time for questions and answers at the end. Please do use the chat box to submit any questions that you may have, or any comments that you might have, or just generally your experience of dealing with patients with multiple comorbidity. Really, really keen to hear from you and to make this an interactive presentation if we can. And if you're and for your future career, I think it's fair to say that generalist skills will be more important everywhere in all specialties, and the number of patients with multimorbidity will just continue to grow. And also, this is a digital tool, so for those who are interested in digital health, please do get in touch as well. I hope you find it useful. So, some background. Our clinical decision support tool is BMJ Best Practice. It's a point-of-care clinical decision support tool aimed at the interdisciplinary team. It's structured around the patient consultation with advice from history and examination to investigations through to management and follow-up. And it's a resource that's evidence-based, continually updated, practical, and accessible. And it's a knowledge resource that's designed to answer your clinical questions. But you don't just get any answer, you'll get an answer that's focused on what's important to you. And so we do research continually amongst our users at BMJ to find out what's important to them and what they need. And we get a few key answers each time we ask. First of all, they want content quickly, at speed. And by at speed, they mean answers within seconds. They want practical information that they can use at the point of care and that can help them drive quality improvement. They expect the content to be accessible, and that means on a mobile, but also on an offline app, and also ultimately integrated into an electronic healthcare record or any other system that they're using, so that the knowledge that they need is only one click away. And they also want to be assured that the content is continually updated and also evidence-based. And yet there are problems with evidence-based medicine, and these problems beset generalists in healthcare professionals, and also those who are interested in digital health, who are trying to develop solutions for those generalists. These problems are from a paper by Trish Greenhaw, who wrote a paper called Evidence-Based Medicine, a Movement in Crisis for the BMJ a few years ago. And there's a wide range of problems. I won't read them all out, but they range everything from information overload through to lack of shared decision making. And jumping to the last one, evidence-based guidelines often map poorly to the real world of complex comorbidity, which is important because we feel that this is an issue underlying many of the other problems that you see. And so the reasons why guidelines are inflexible, rules mechanical, prompts technology driven, is because of comorbidities. And it leads to the refrain that evidence-based medicine doesn't work in the real world and cannot deliver quality improvement. And so we think that if we can tackle the issue of comorbidities, it could help with lots of others of these problems and knock out lots of other problems as well. And this led us to look hard at the problem or the challenge of managing patients with comorbidities. And I know this is a healthcare audience, but comorbidities is when patients have more than one illness. And comorbidities are important, and yet they're much neglected. This is a quote from the paper in the BMJ, Rising to the Challenge of Multimorbidity, published in January or February of this year, a paper by Chris Whitty and the CMOs of the other nations. This was Chris Whitty before he became a household name in the UK. And they wrote that training from medical school onwards, clinical teams and clinical guidelines all tend to be organised along single disease or single organ lines. And we have looked at detail at the problems with comorbidities. 1 in 4 adults in the UK suffers from multiple chronic conditions. Remarkably, in the UK, 1 in 3 adults admitted to hospital as an emergency have 5 or more conditions. People with multimorbidity have poorer functional status, quality of life and health outcomes, higher users of care, higher mortality, which poses a significant problem for healthcare systems. And yet resources for healthcare professionals focus only on single conditions, and that includes original research and systematic reviews and guidelines and clinical decision support resources up to now as well. And we've looked specifically at comorbidities in the acute setting. Most patients in the acute setting have more than one condition, yet clinical resources only focus on single conditions. And when comorbidities aren't taken into account, patients get suboptimal care and worse clinical outcomes and longer lengths of stay and increased cost as a result. Comorbidities are not restricted to elderly patients. Young patients, middle-aged patients can have comorbidities also. Interestingly, comorbidities are associated with socioeconomic deprivation. And if you're poor, you're more likely to have comorbidities, and you're more likely to run into problems with those comorbidities younger. So with all these problems, we thought at BMJ, we're going to have to look at this in more detail. And so, as I said earlier, we continue to do research amongst our users, key kind of groups of users in this field. And first and foremost is junior doctors, because of course they deliver large parts of the care. And we interviewed junior doctors, did focus groups amongst them, and they are worried about treating patients with comorbidities. They find it difficult. They worry they'll treat something which will make something else worse. They worry comorbidities could be neglected or overlooked. They find management difficult. They lack confidence in decision making, particularly at transition points in their career. For example, moving into the foundation program for the first time when they graduate, and it's the first time they've been confronted with the problem of patients with multiple diseases, and sometimes the guidelines that they've learned up to now won't fit these complex patients who might have COPD and CCF, COPD and cardiac failure, as opposed to just having COPD on its own. And senior clinicians find it concerning as well, and they're worried about junior clinicians, and they're worried junior clinicians will forget to consider comorbidities. They're worried that they lack time to answer questions, or what will happen when clear guidance or expert opinion isn't available, for example, in the middle of the night. And healthcare providers or hospitals are worried about senior clinicians, junior clinicians, and also quality of care and cost. And underneath cost, both length of stay and readmissions. So we thought we have to do something about this. And so we have very recently launched the BMJ Best Practice Comorbidities Tool. And what you do is you add the patient's comorbidities to an existing management plan and get a tailored plan. And the idea is that it supports healthcare professionals in treating the whole patient and thus delivering holistic care, which is what we want digital health to deliver, but so often it doesn't, largely because guidelines are focused on single conditions. A problem which has been known about for a long time. I started my training in geriatric medicine back in 1997, and it was clearly an issue then, and we've made slow progress in dealing with it. So the idea is that you have a patient with, say, pneumonia, an acute condition, and you can add one or more of these chronic comorbidities to that acute condition. And what happens is you get an exponential number of potential combinations or permutations. And this is important because combinations are common and single diseases are increasingly rare in hospitals. A cardiologist told me recently that he couldn't remember the last time he saw a patient with a single disease. And I spoke with an elderly person's doctor last week on this subject, and he said, we just don't see anybody with single diseases at all. Now, the content for the tool has been put together by our editorial team and also an external expert panel. And here are members of the external expert panel, and I won't read them all out, but many of them are national or international figures in their various fields. And thus far, the comorbidities tool from BMJ Best Practice is the only clinical decision support tool designed to address comorbidities. So, how does it work in practice? Well, this is a clinical tool, so we've put together a clinical scenario to bring it to life, and importantly, to look at this from the patient experience point of view also, as well as from the healthcare professionals' point of view, because I think that's another failing in digital health, is that too often it's about the purist approach to evidence-based medicine, too much about the research and professional expertise, and patients' needs, preferences, desires aren't paid sufficient attention. So here's the scenario. Imagine for a minute that we have an 82-year-old man who comes to the emergency department on a Friday evening with cough and shortness of breath, coughing up green, purulent sputum. Symptoms have been going on for 3 days, getting worse. past history of chronic bronchitis in an ex-smoker, type 2 diabetes in the background, and he's got wheezes and crackles in the chest, takes inhalers and metformin. So you don't need to be an older person's doctor to work out that this man has an acute exacerbation of COPD and type 2 diabetes. It's not a diagnostic challenge, and yet it is a therapeutic one. So let's see how the scenario plays out. So imagine the scenario splits into, and in scenario A on the left, the doctor looking after this patient just deals with the acute condition, the acute exacerbation of COPD, and advises nebulized bronchodilators, steroids, oxygen, antibiotics. In scenario B, using the comorbidity tool, the doctor or healthcare professional will give all those treatments, but with careful monitoring of the steroid in light of the type 2 diabetes, and indeed will review the diabetes medication, will continue to monitor and manage the blood glucose closely during the hospital admission because of the steroids and the acute illness, and all important, will check the patient's feet. And why? Because that's exactly what the comorbidity tool tells you to do. And thus we get to dynamic algorithms that evolve and change as the patients change. And so what happens with these scenarios? Well, when you give the correct treatment, the COPD should start to improve and the diabetes remain under control. But when you don't, let's look at what happens on the left. No careful management of the diabetes despite taking steroids. Hyperglycemia will result, quite possibly renal impairment in an older patient. No review of the diabetes medication, metformin not reviewed as it should be, renal impairment will get worse. No check of the patient's feet, and a pressure ulcer in somebody with diabetes. These are all too common problems which those of us who work or have worked in the hospital setting will recognize very well. And so within a few days, one patient is starting to improve and you're planning to discharge him home. The other patient, you're planning to discharge him to the high dependency unit with uncontrolled diabetes, renal impairment, and a pressure ulcer. Now, it is possible to rescue these patients and to enable these patients to recover, but so much better if this weren't to happen in the first place. And so, after a prolonged hospital stay, this person whose comorbidities were not managed optimally initially slowly improves and goes home as well. And I know I've skipped through that, so let's pause for a second and slow down and review what's happened. And first of all, from the patient experience point of view, this patient has had pain and inconvenience and discomfort and distress. From the healthcare provider or hospital point of view, there's been poor quality care and also increased cost. And the increased cost related to the number of bed days and the type of bed days, and also treatment and follow-up of the foot ulcer. And so it all adds up. Now, how common is this problem? Or is this something that BMJ has just dreamt up? Well, diabetes is a comorbid condition in 10 to 20% of patients with COPD. Globally, COPD causes the death of 2.9 million people annually. In England, there are about 100,000 admissions caused by COPD every year. And remember, this is just one comorbidity added to one condition. And 1 in 3 patients admitted to hospital as an emergency will have 5 or more conditions. But it's not just this combination. Let's look at hip fracture and hypertension. 60% of patients with hip fracture also have hypertension. Globally, hip fractures will affect around 18% of women and 6% of men. There's about 65,000 hip fractures in the UK every year. And if the hypertension isn't managed correctly, then you will get hypertension, probably postural hypertension, falls, and heart failure. It's quite possible that postural hypertension caused the hip fracture in the first place. And comorbidities are universal. I've given talks on this subject to audiences around the world, and certainly to within England and also Scotland and Wales. And I always do some homework or local research before I give a talk, and I always find problems with comorbidities. And here's just some examples. What we know about comorbidities in the UK largely comes from Scotland, where this study by Barnett et al. Found that 23% of patients in a study were multimorbid. And multimorbidity increased substantially with age, and yet the absolute number of people with multimorbidity was higher in those younger than 65 years. So it's not just an older person's problem. And interestingly, he also pointed out the presence of a mental health disorder increased as the number of physical morbidities increased. Mental health comorbidities very commonly neglected. Asia, multimorbidity, 1 in 10 urban South Asians. And in Australia, I quote this one partly because they talk about the issue of complex comorbidity. And complex comorbidity has different meanings, but often it means patients who have 3 or more conditions, which is a considerable burden of illnesses, and it puts a considerable pressure on healthcare services. So what I'm going to do now is do a brief live demo of the tool. So I'm just going to go to Best Practice, the homepage. For those of you who use it, they'll be familiar with this homepage. And we'll go to a patient, we'll put acute exacerbation of COPD into the search box, and we'll come to the topic on acute exacerbation of COPD. We want to get on and treat this patient without delay. So we'll click on the treatment algorithm, and you're asked, does your patient have any comorbidities? And we said, yes, the patient does. So we'll click on diabetes, and we'll then click on show the treatment algorithm. And then we'll scroll down slowly till we get to acute on presentation. And what do we see? Well, like we said in the slideshow, our patient is, the advice is the patient to receive bronchodilators, steroids, oxygen, antibiotics, and consider other treatments. But you can see now these C icons or comorbidity icons have appeared. And it's appeared, first of all, beside the steroids. And so you can say it says, manage the patient's diabetes carefully when they're taking steroids, because it will worsen their glycemic control. And the C icon appears here. Review the patient's diabetes medications and withhold metformin if they develop renal impairment. And lastly, all important, check the patient's feet so that you can ensure they get a pressure relieving mattress if that's required, and also they don't develop a pressure ulcer. I'm just going to show you one other one now. We'll go back to BMJ best practice, and a topical one now, coronavirus disease. Our patient has coronavirus, and we'll go to the treatment algorithm and say, we'll think of other comorbidities now. This time we'll say our patient has heart failure and also depression. And so we're adding 2 comorbidities on this occasion, and we'll show the treatment algorithm now. And let's imagine that our patient has severe COVID-19 infection, unfortunately, all too common at the moment. And so you can see it advises hospital admission, oxygen therapy, symptomatic and supportive care, all these different things, but also steroids and dexamethasone. So we'll just scroll down here, and it says, of course, your patient has depression, so you need to be very careful when giving them steroids. So that comorbidity is taken into account. And let's click on remdesivir, and it says, in patients with heart failure, you need to be careful of renal impairment in a patient with heart failure. And when choosing antipyretics and analgesics, all important, be careful of non-steroidals in patients with kidney disease, heart failure. And absolutely, last one, weigh up the risks and benefits of cardiovascular or kidney medication, such as ACE inhibitors or other such treatments. And so that's COVID-19 and comorbidities. Now I'm just going to skip back to my slides, and this is the last slide, I think. And so the purpose of the comorbidities tool is to improve the quality of care, ensure patient safety, drive patient-centered care, avoid complications, save costs, things that everyone else is trying to do. What makes us different? Well, what we're trying to do here is to have a clinical tool and also a digital tool that helps with real-life patients with multiple real-life illnesses. And it's trying to do a difficult thing, which is to get healthcare professionals to stop and think. Sorry, Ben, I think you might need to mute yourself. Sorry. To get healthcare professionals to stop and think, and to make a strategic step in patients with evidence-based medicine and clinical decision support, and move from academe to the coalface, from fragmentation to holistic care, and from single diseases to comorbidities. Thank you very much for listening, and I'm very happy to answer any questions that you may have. I'm going to stop the slide share now, but I'm very happy to answer any questions that might have appeared, and also discuss more generally other issues related to comorbidities. Hello. Hi, Benedict.
And medical school at least, were taught in blocks and were taught about specific diseases sort of one at a time. And when it comes to learning about comorbid conditions, that's usually what you start to learn in your clinical years. But before that, when you're having exams, you're usually revising for questions which are about one particular patient who has one particular disease, and you're sort of either trying to diagnose them or treat the condition. So what would since comorbidities are so common in clinical practice, do you think that should be reflected more in medical school teaching and in the sort of questions they ask?
Yeah, I think it should. And so the undergraduate curriculum, I think it needs to take into account much more the needs of patients and population, which doctors, when they graduate, they're going to serve, which is predominantly older people and people with multiple illnesses. And so we know that we've got medical students, particularly in their last 2 years, their clinical years, to use the tool and to try the tool in simulated scenarios. And they've told us that they found it helpful. And so I think there is a big role for a tool like this, because ultimately it's at a time of transition when you stop being a medical student and being a foundation year doctor for the first time, and then you're told, okay, can you prescribe fluids to that patient who has COPD? They also have heart failure. And that's the first time you've been asked to deal with things like that when you qualify. So I think the tool absolutely does have a role in undergraduate clinical education as well as postgraduate education too.
Yeah, definitely. I think we've got one question in the chat. They've said, how do you think this algorithm will help healthcare professionals in the future?
So we're really just at the start of our work in comorbidities. So currently we have 30 acute conditions to which you can add up to 10 comorbidities. Um, we plan to grow the tool to make it bigger, but also already we're thinking about comorbidities in other settings, like primary care settings. And there's a range of other kind of further developments of the tool, one of which is further integration into other clinical systems, digital systems that doctors and other healthcare professionals use. And we can do that now. And we can do simple integration through the so-called HL7 info button, but also more sophisticated API type integration, which enables much more granular linking. I think those are that's in the immediate future, if not now. What will happen in 5 years, 10 years time? I don't know. It's interesting to debate that. It may be that I suppose you can start to think about automated decision support and robots and machine learning, and we're not there yet. But you wonder, in 5 years' time, is that what we'll be talking about in the context of clinical decision support, where, say, um, your patient's healthcare record is pre-populated with multimorbid diseases that they have, and therefore suggestions are automated, or maybe they're more than suggestions. Maybe the clinical decision support tool itself is directing treatment, and we're not there yet, but that could be one of the futures.
And just one more question. On the topic of AI and machine learning, like you said, there could soon be a lot of automated decision making and obviously your clinical decision support tools. So do you think that's later on going to, I don't know how to say, make doctors feel like they're maybe sort of losing their job, or maybe not as needed anymore?
Yeah, so that's a common question that I get asked, and I think the short answer is no, probably not. Like technology has come on massively over the past 20 years, but it hasn't resulted in less need for doctors. There's more need for doctors. I think what I think the future is about doctors or other healthcare professionals working in partnership with the technology. And I think I'm misquoting Eric Topol now when I say this, but he said, I think something along the lines of, it's not that digital health will render doctors redundant, but he says doctors who aren't aligned with the digital health revolution, then they will quite possibly be left behind. And we can see this with the appetite for integration with the appetite for having the resource on an offline app. So we've got an app which is quick to download and uses a small amount of space on your phone, but it's compatible with any type of smartphone. And we can see big usage on the app. And I think that is just one small example of kind of the digital appetite of our learners, medical students, and junior doctors and other healthcare professionals who are keen to use resources on digital devices that they use already, and they've got enormously high expectations of the healthcare digital resources, and sometimes those expectations are frankly not met, but we're committed to doing our best to see if we can meet them.
Thank you very much, Dr. Walsh. That was very insightful and interesting. I use BMJ practice every single day in my revision, so it was really relevant. Nice to know the sort of new fun and things. So that's really useful.
Well,
and
great,
also
fantastic.
really
Thanks, Benefit. I'm delighted to hear that. And one thing I should have said is that BMJ Best Practice is free to the NHS. So if you work in the NHS in England, Wales, or Scotland, it's freely available. So please do use it. But also, there are not all of the comorbidity tool is freely available, but some of it we've made freely available. Specifically, the COPD, the acute exacerbation of COPD topic, is freely available, and also the COVID-19 topic will remain freely available throughout the duration of the pandemic. So Benedict and others, please do have a look at that tool as well. And if you have suggestions on how we could make it better, or other things that we should be doing in clinical decision support or in multimorbidities, please do let us know. It's talking to people like yourself or other junior doctors that have enabled us to build the tool. Like, I'll give you another example. When we were building it first, we were saying, okay, how many comorbidities should you be able to add to the treatment algorithm? Should we just allow people to add one? And we tested it with junior doctors who said, all my patients have 5 or more comorbidities. I want to be able to add lots of comorbidities to the treatment algorithm. And so that's the tool we ultimately developed.
That's great. Thank you very much, Dr. Welsh. Now I don't have any more questions, so I think yeah, we can leave it there. I think I'll put in the chat if anyone has any more any questions they'd like to ask. I will ask them to send you a private message on the platform.
Yeah, that would be great. And could you put my email address on the chat as well, Benedict? I should have done that. My email, you may have my email address there in front of you, but if not, it's KM Walsh, WALSH, @bmj.com.
Yep, I'll put that in now for you.
Fantastic, and we're delighted if people want to join, want to comment on the tool, or if people are struggling to get access to it, let us know and we'll sort it out for you.
Yep, definitely, absolutely. Thank you very much for that.
That's a pleasure. Thank you very much for fielding the questions and coming up with the questions yourself. Very helpful.